So let's complete urology, urosurgery from MRCS. Topics include the prostate gland disorders, testicular tumors, testicular disorders, penile disorder, urinary tract infections, urinary tract stones, and all that. It's around 20, roughly 25 or something pages. So let's see what about prostate glands. What is given about prostate gland disorders? This is benign prostatic hyperplasia. This is always hyperplasia. This is one question. So you have to remember the question wise topics. So I will try to maintain this. What are the questions? This is one question about hyperplasia. The incidence in males above 80 is side effects of median lobe. It is median lobe is for benign and cancers, malignancy and the posterior lobe. This is another question. Palpation, it is smooth. In benign, there can be retention, hematuria, hesitancy. Intravesical pressure increases, prostate disorder can lead to bladder diverticulum. So this per rectal examination, how it is done, digital rectal examination, it gives size of the prostate and deep state include. Uroflowmetry, this reduces less than 15 ml per second. UFO, uroflowmetry. Exclude the bladder obstruction. So what are the management? There is fluid intake management. Medical therapy is alpha blocker. The questions coming is, if prostate is more than 30 grams or PSA is 1.4, add 5 alpha reductase. Intermittent catheterization and long-term catheter may be used. So what is that? There are two. One is alpha blocker. This is another question. Alpha blocker and 5 alpha reductase. This is another question. 5 alpha is 5 finasteride. F is 5. F is 5. So alpha blocker is different than 5 alpha reductase inhibitor. Alpha is tamsulosin. So 5 alpha finasteride is finasteride. So it is slow. Tamsulosin is fast. This is another question. Slow onset is finasteride. So incidence of acute retention is low in this. So it is slow onset, therefore more adverse effect. TURP is done smaller than 30 grams. Then all the other open prostatectomy, acrodonized gland, do not minimally invasive treatment includes transurethral ablation is not done. Prostate cancer, again this affects posterior lobe. This is one thing. Then adenocarcinoma. This is adeno. Malignancy of the prostate is adeno. This is question. Multifocal and peripheral. This is another question. Tumor testosterone dependent. This is another question. Now what is the grading of the tumor? Gleason's grading is done. 12 biopsies are taken. Each biopsy 1 to 5 score. 1 is lowest and 5 is worst. The most abundant scores are summed up to give final score. For example, 4 plus 3, most abundant two scores are 3 and 4. So 4 is more abundant than 3. So 3, when first letter is smaller, it is better. This is another question. First letter is smaller is better prognosis than first letter is larger. 1-2 grades are often given also with no symptoms. So least clinical observed score is 6. 3 plus 3. This is least score. So it doesn't start from 0. Then 10 is the worst. So this is 1. Grade 1 is 6. 2, 3, 4, 5. There are 5 grades. So it's starting from 6, 7, 7, 4th is 8, and this is 9 to 10. So why this is 277? This is 3 plus 4, and this is 4 plus 3. Then this is 8, 9 and 10. Upon diagnosis, patient lymphatic spread. This is another question. Prostate lymphatic spread to internal iliac and obturator node. Lymphatic spread of prostate is internal iliac and obturator. Blood spray most common mainly due to bone causing osteosclerotic. This is another question. It is osteosclerotic vertebral lesion, back pain, stimulation. Vertebral metastasis occurs through This is another question. Vertebral venous plexus, which can connect to vertebral vein. TNM classification, most of them not asked, but confined to prostate is T2, extra prostatic is T3, and then seminal vesicle. No lymph nodes, positive lymph nodes, N1. PSA, it can be prostatic. Digital rectal examination 1, PSA is second, and MRI is done. Biopsy for grading. So treatment modalities: active surveillance in 6, PSA less than 10. If it is 8 and above, you go radical prostatectomy and radiotherapy. Coming to testicular tumors, differential diagnosis of inguinal scrotal swelling. This is transillumination positive, transillumination negative. Negative, positive. Positive means there is fluid. It can be hydrocele, it can be spermatocele. Hydrocele, ligate it, process vaginalis. Adult, chabulis repair from the inguinal incision. Children, inguinal incision. Spermatocele, excision. This is the question, this is the question, this is the question. Now transillumination negative means it is hernia or tumors. So hernia, herniorrhaphy, hernioplasty. It is reducible, expansile cuff. In testicular tumor, weight loss, metastasis, alpha fetoprotein, beta HCG. This orchidectomy through inguinal approach. This is the question. Biopsy is never done. This is the question. So now it is what type of swelling, whether it is painful, trauma, non-traumatic. Painful, swollen testis, non-traumatic. Post-traumatic, not improved with elevation of testis. Swollen testis elevated, testicular torsion. After elevation, it doesn't improve, it is torsion. So urgent exploration, this is the question. For torsion, you need urgent exploration. How is the question? Then traumatic, fever, dysplasia, this is non-traumatic. There can be infection. This is urological procedure, viral inflammation, medical treatment. And varicocele is pampiniform plexus. Testicular veins, this is again question, this is question. Last cremastic reflex when the cord is compressed. Testicular torsion has got last cremastic genitofemoral torsion of hydrated. This is again question. Vasectomy causes sperm granuloma. This is question. Post vasectomy. Rhabdomyosarcoma, 4 months lymphoid spread is there. Another question. Leydig cell tumor associated with gynecomastia. So gynecomastia, you have to evaluate testis. So how are the testicular tumors? Seminoma. Germ cell tumors are more common. Most common germ cell tumor. Among that, seminoma, non-seminoma, teratoma, embryonal yolk cell carcinoma, and all that. Clinical picture, mass is there. Painless. Hydrocele can be there. This is question. Hydrocele can be there. Supraclavicular lymph node and bone pains, gynecomastia. So you have to evaluate testis. Investigation is biopsy is never done. Question. Metastatic has by CT abdomen for lymph node metastasis. So this is one. Beta HCG, choriocarcinoma, alpha fetoprotein, go for embryonal, fetoprotein, fetal yolk sac, LDH non-specific. Classical seminoma, 30 years, teratoma, younger age group. So what is the difference in this? This is radiosensitive. This is question. Seminoma is radiosensitive and teratoma is more aggressive. You have got different types of tissues. Radical orchidectomy is the treatment. Penile disorders, more than 4 hours. Low flow, high flow. Low flow means it is venous. High flow is arterial. So the treatment if emergency is within compartment syndrome. So this is an emergency. Low flow, venous is an emergency. While high flow is a fistula, it resolves spontaneously. High flow. This is the paradox. So low flow venous, it requires treatment All investigations should not delay full blood count and all that. So ischemic priapism, not to be penile fractures, condition with associated section. This is one question. Surgical exploration is urgent. This is question. This can occur in sickle cell anemia. This is another question. Now what is this? Aspiration, corporal washout. So if shunt procedure, MRI, ischemic priapism, you need aspiration and the washout. This is the question. Venous low flow, urinary tract disorders, most common. This is the question. Most common. Calcium oxalate. This is the question for steroid, Proteus. Radiolucent is urate. Familial xanthine, cysteine, again familial. Hematuria, loin pain. Ureteric stone, hematuria, pain from loin to ground. Urinary bladder, hematuria. Less than 1 mm, up to 2 mm, they pass. So this is the question. Wait for passage. Diagnostic tool for the school is CT. Less than 5 mm, wait and watch. 5 to 10, failed for stone removal. So if more than 10, what to do? Percutaneous nephrolithotomy, more than 15. If less than 15, localization stone. Upper middle pole doesn't affect obesity, URS and shock lithotripsy. If it is lower pole, again URS. If it is more, then PCNL. Now location of the stone. Dual of the ureteral stone. Ureter. Distal ureter, URS. This is question. Proximal, more than 10, less than 10. More than 10 millimeter, it is not possible to pass, so go for this. Does patient have one of the more obesity, URS and SWL? Complication of urinary tract stones, there can be retention, catheter, chronic retention, sterile hydronephrosis, percutaneous nephrosis. This is one question. PCN is done. Fever and everything is there. Incidence present mole, frying pan, fever, weight loss. Investigation choice is CT scan. MAC 3 is also good. Post-operative urination may be spinal and epidural analgesia, urethral stones, diabetes. So bladder pain tumor syndrome. This is interstitial cystitis. This is again question. 4 weeks identify etiology. Incidence. Patients have symptoms with bladder digestion improving while avoiding. IBS, fibromyalgia. Exclude the other causes. Clinical symptoms of interstitial. Urgency is there. Daytime frequency. This is interstitial cystitis. Not trauma. So membranous urethra, bulbar urethra and bladder. 3 different types of injuries. So straddle injury, bulbar. Blood at the meatus, perineal hematoma. This is the question. Ascending urethrogram is the investigation. You just check, and treatment is suprapubic SPC. So catheter is contraindicated. These are all questions. Now membranous, you get prostate dislodge, high riding prostate. Fracture of pelvis, again intra and extraperitoneal retention, suprapubic free fluid in the abdomen is extraperitoneal is conservative management, intraperitoneal is laparotomy. Full bladder seat belt injury, seat belt full bladder is intraperitoneal, and fracture pelvis is extraperitoneal. So tumors of urinary tract, renal, it is also called as renal cell carcinoma, adenocarcinoma, hypernephroma, Graves' tumor. These are the different names. Most common renal tumor is renal cell carcinoma. Then risk is smoking. This is coming. Then clear cell, most common among these. Spread is for lung metastasis. use clear cell or called cannonball. This is question, this is question, this is question. Painless hematuria is there, mass is there, sometimes pain can be there. There is left varicocele, paraneoplastic syndromes can be there, polycythemia, this is one question. Hypercalcemia is again question. Stoffer syndrome, liver. CT is the investigation. Venous thrombosis is anyway. Biopsy is advanced cases for only chemotherapy, radiotherapy. Partial nephrectomy if less than 4. Radical nephrectomy is more than 4. Transitions. So bladder cancer is transitional. Occupational naphthalene, rubber, textile, PVC, smoking. This is very common question. All these workers. Frank painless hematuria. Cystoscopy biopsy is the gold standard. Non-invasive way there, cystoscopic follow-up 3 to 8 months. Muscle invasive is there, neoadjuvant, radical and ureteric involvement, segmental resection, radical nephrourectomy if it is Wahi. This occurs, squamous cell carcinoma of the bladder occurs because of chronic irritation and metaplasia of transitional to become squamous. So bladder, urinary bladder has got transitional epithelium. Cystosomium, staghorn stones, these are the other radical cystosomium. Transitional epithelium is called as urothelium. It is also called as urothelium. Transitional cell carcinoma can be pink. This is question. What are the different types of stress incontinence? Incontinence occurs when increased abdominal pressure, coughing, sneeze, and urinary overactive bladder is detrusor instability. So in overactive there is bladder training. Well, this stress incontinence there is pelvic floor exercises.